Şimdi de klinik pratiğimizde belki çok sık karşılaşmıyoruz ama karşılaştığımızda da tedavisinde oldukça zorlandığımız bir konuyu anlatmak üzere Jose Medina Polo'yu podyuma davet ediyorum. Jose Medina Polo, İbero-Amerikan Nöroüroloji ve Ürojinekoloji Derneği adına konuşmacı olarak burada bulunuyor. İspanya Madrid'den geliyor. İlgi alanı özellikle üriner sistem enfeksiyonları. Bu konuda çok sayıda çalışması ve yayınları mevcut. Avrupa Üroloji Derneği alt branşı üriner sistem enfeksiyonları board'unda da çalışmaları mevcut. Please.
Yes, thank you very much for the invitation for all the committee, and I'm going to talk some minutes about the antibiotic treatment, non-antibiotic treatment of patients with recurrent urinary tract infection. This is the patient that we had to treat. More or less half of the women had an infection during the last time, and it's supposed that 30% of this had a recurrent urinary tract infection, and the 2% of all women, and we had a lot of millions of women in Spain and also here in Turkey, suffer very frequent urinary tract infections. So it's a topic that we had to deal as urologists. First of all, and before to talk something about treatment, I'm going to introduce some risk factor or urinary tract infection. As you can see, we had to differentiate between premenopausal and postmenopausal women. And it's important that a risk factor for infection in both cases is antimicrobial use of antibiotics in both cases. So it's important not to treat asymptomatic bacteriuria, and we need the antibiotics only in required cases. Another thing I want to state at the introduction is the hypothesis that we think that is the correct nowadays about the why some patients had recurrent infections, some patients that they don't do anything special. We think that the patient suffer an infection and is created a reservoir, an intracellular reservoir in the urothelium that produce the infection. The cell is going to apoptosis, and then the symptoms occur again. And going to my topics, we need to treat the infection, and we also need to prevent the infection. The usual way to treat the infection was antibiotic prophylaxis. Some words about this. There are different antibiotics that we can use, but we need to know some things. First of all, we don't know the optimal time for the prophylaxis with antibiotics. It's supposed that it has to be more than a year. Secondly, more than 20–30% of the patient abandon the prophylaxis, and most of them due to side effect. And moreover, more patients don't want to use antibiotics. And it's also true that antibiotic prophylaxis is related with a higher incidence of infection in comparison with no antibiotic prophylaxis, and it's also associated with multi-drug resistant microorganisms. So we need to go to no antibiotic prophylaxis. I follow this scheme that was previously published that summarized all the measures that we had: behavioral change, Dimanose, cranberries, bacteriophages, immunoprophylaxis, and this is the thing that I'm going to review. First of all, behavioral modification. There is not a great evidence about this. At least related, there are not many articles reviewing this. I usually recommend this revision that was presented several years ago in the European meeting, and with a nurse dedicated to explain the patient during 20 minutes how to prevent infection. They reduce, especially in patients with infection related with sexual intercourse, the number of infection in 2/3. So it's important to have the time. Sometimes we don't have the time. We need the nurse to explain how to prevent the infection. Secondly, regarding the cranberries, the edema nose, the guidelines don't give a real recommendation because the studies published are very numerous and they include different substance. They include a different quantity of cranberry or edema nose, and this is the thing. We can offer the patient, and we need to enforce that the evidence about the effectiveness is contradictory. I mentioned this meta-analysis. As you can see, there are different data, but if we go into the study, the concentration of cranberry is very heterogeneous. But one thing that we know that it's seen it we increase the percentage of cranberry in the products, we had the best effect, especially when the pack is more than 75 milligrams. Okay. Secondly, usually if we think about cranberry, it's better to combine with the nose. Sometimes it's not only a treatment, and we need a combination of treatment. There are heterogeneous results, but the best result is with the one. They treat the patient with 2 grams of dimanose, and they compare with nitrofurantoin at prophylaxis, and they found that the result between antibiotic and dimanose was quite similar. But we need more studies and we need homogeneous result. But we had a high grade of evidence regarding estrogen, the vaginal estrogen. They provide a reduction of infection. And with dimanose and cranberry, we can discuss, but with estrogen, we don't discuss. We need to recommend vaginal, not oral, the estrogen to our women that in the menopausal age or in those with vaginal atrophy. For example, some patient with 40 years and a previous gynecological surgery with infection. Move on to the probiotics. The probiotics, the evidence is weak and it's quite similar to cranberry and the manose. It's not clear, but it's supposed that the restoration of probiotics might prevent urinary tract infection. What is the hypothesis about the mechanism? Is important to ureterial mucosa acidification, and in my patient, I usually use something to a better acid pH in the urine. That it's important that the pH in the urine is related with the effect of antibiotic, and usually in patients with infection, I had the urine pH. And according to the urine pH, I select the antibiotic because not all the antibiotics are the same. Moreover, the probiotics have a synergy with the immune system, and it can be used, but there are not clear evidence. And we think that the higher evidence is with Lactobacillus species. That is important to select the correct probiotics. But apart from estrogen, vaginal estrogen, there are poor evidence about everything. We had an evidence 1A and a strong recommendation about immunoprophylaxis. But what we had when we call about immunoprophylaxis, we had different compounds. Not in every country is the same available. The long evidence is about Eurovaxon that was available from more than 4 decades. It's consisting orally capsule with E. coli lysate and had an stimulation of the immune system. The result is good, and it was approved by the guidelines signed more than 3 years. The problem, they had a lot of side effects, especially gastrointestinal. We had another compound that is the one available in Spain, that is the Euromoon. It's a sublingual immunoprophylaxis consisting in inactivate bacteria, and the patient did during 3 months, and it was included this year in 2023 in the guidelines. Other compound, the sulco-urobat, is one injection, intramuscular or vaginal with a buster, and the results are promising, but there are few results. But not of these are real vaccination. Vaccination we can include in the SPED, because when we think about vaccination, we think about something that you drink, for example, the polio, or an injection that prevents the infection before to have the infection. And this product we give to patients with infection. So this is the future. My last slide is going to what is the future about the treatment of infection. This is the meta-analysis about the immunoprophylaxis. The study by Lorenzo Gomez is about the Euromoon, the one available in Spain, and the one by Wallenberger and Frey and Hodgkin are the one about the Eurobazon. As you can see, the results are good in all of them. Regarding the Euromoon, the one that available in Spain, depend the country, we had the preparation of 4 types of uropathogens that the patient take, and we can also use white autovaccine. We take a culture of the patient when she has an infection and produce the vaccine with the microorganisms that the patient had, and we demonstrate that the results are better. This is the preparate, and this is with autovaccine, is better with the preparate with 4 microorganisms. And the reason is that we had cross response with the microorganisms. So we don't need always to have the euro microorganism to produce the vaccine for the patient, because usually the urinary tract infections are produced with the same microorganisms. And regarding the prophylaxis in pregnancy, it's a question that we had, because usually we can use the immunoprophylaxis. This is an study with Eurobazon that they give Eurobazon to patients with pregnant, and they report less recurrent, and they report less antibiotic therapy with no effect in the fetus. But we don't need the approval, because usually the insurance is very expensive. It's the only reason, because we can use. And finally, I talk about the future. The future is going to be a real vaccination, a vaccination that we give to the patient. For example, patients that are in a hospital, in a nursery, patient with a catheter, we did a vaccination and prevent the infection of the future. There are studies about this. You can see with different one. The first one is with animal, that they saw that the antibodies had in the blood, and those for many years. And the second study is with human. We are collaborating in the last one by Janssen, is for patients more than 60 years. And the best thing is that we had lots of side effects, and we are waiting for the result. But I think that in 20 years, this is what we are going to do a vaccination, a real vaccination to patients we had an infection. This is the result in animal. As you can see, the antibodies was maintained in the blood, and the patient had less infection. So to reach a conclusion, Recurring urinary tract infection had an important effect in quality of life. We can ask the patient had an important effect in the sexual life, and in my group we are doing research in the sexual life of the patient. The first step in the management of infection is to control possible etiologic factor that might contribute to the development of the infection. For example, a prolapse, some related to sexual intercourse, the intake, and we recommend to prevent the infection first to use the antibiotic, use other measures. Topical estrogen in postmenopausal women, we had a high rate of evidence, and we also had a great evidence that is promising with immunoprophylaxis. And finally, I'm going to invite you maybe to the SINUC, that is the Spanish Congress in 2 weeks, but the next year we had the ICS in Madrid, in my city. This is a short video to promote my city, and I hope to see you all in Madrid. Thank you very much.
Teşekkür ediyoruz Jose Maria Polo'ya, Medina Polo'ya. Soru ve katkıları olan varsa buyurun hocam.
Bence bu kongrenin en önemli konularından birisinden biraz hafif bahsedildi. Çünkü insan vücudunda 2 kilodan fazla probiyotikler var. Probiyotik başka, prebiyotik başka. Çok güzel anlatıldı. O kadar çok gereksiz yere antibiyotik kullanılıyor ki bu probiyotikler mahvoluyor. Bence en iyi probiyotik düzenli egzersiz yapmaktır, immün sistemi artırmaktır. Bunlar tabii güzel, yardımcı. Fakat hayat tarzı değişikliği, kilo almama, düzenli aktivite, bunlar en iri probiyotiktir. Bu konuyu getirdiği için de ben kongreye teşekkür ediyorum.
Buyurun Cüneyt Hocam. Ses geldi hocam.
Açık mı? Sevgili Jose, seni burada görmekten çok mutlu olduğumu ifade etmek istiyorum. Seninle ilgili kısa da bir bilgi paylaşmak istiyorum. İspanyol Kadın Ürolojisi grubunun en parlak akademisyenlerinden biridir kendisi. Hem genç hem de en parlak. Gelecekte de çok farklı yerlerde kendisini göreceğimizden hiç kuşkum yok. Benim merak ettiğim soru şu. İlk defa ben açıkçası bu bilgiyi senden bu prezentasyonda aldım. Bu immünoaktif ajanlar acaba cost efektivite açısından antiseptiklerle karşılaştırıldığında durum nedir? Onu öğrenmek istiyorum.
Well, first of all, I want to see some word about probiotics and microbiome. It's not only gives probiotics for the patient. We know that there are some things that change the microbiome and they change the bacteria in the gut. For example, all the drinks and all the food without zero sugar is like rubes. They destroy the normal probiotics in the gut, and we must to discuss to the patient. And regarding the second question about the immunoprophylaxis, currently the studies with immunoprophylaxis with the best result is a comparison of the auto-vaccination with the auto-immunoprophylaxis with a prophylaxis of antibiotics. And it's important to say the patient that there are an improvement in the number of infections. The percentage of patients, more or less, that they don't have infection in 6 months is about 60%, but in many cases the infection appear. But it's important to explain the patient if the reduction in infection is the 80%, is a good result. And another thing is sometimes it's required to repeat the immunoprophylaxis. For example, in my setting, we usually recommend 6 months of immunoprophylaxis to patients with are immunocompromised. For example, to kidney transplantation patients that in my hospital we had many patients. And when the infection appear, especially after 1 year, sometimes it's necessary to repeat the immunoprophylaxis.
Son 2 soru, evet Levent Hocam.
Ben bu güzel sunum için çok teşekkür ediyorum ama bir şey duymak isterdim aslında. Bu tekrarlayan kadın enfeksiyonlarında, idrar yolu enfeksiyonlarında trigonun öneminden. Aslında trigonit tanımı çok eskidir. Tabii 1927'lere kadar uzanır ama ilaç endüstrisinin stimülasyonuyla daha çok antibiyotiklere yönelmiştir. Ama çok yeni yazılar biliyoruz. Ürolojide daha 2023 Ocak ayında yayınlandı. Elektrofulgürasyondan da bahsetmenizi beklerdim. Çünkü bir yılın sonunda %90'ların üzerinde pozitif yanıtlar alınıyor. Çünkü biliyoruz ki trigon mezoderm kökenli, diğer her taraf endoderm kökenli ve tavşan çalışmaları buranın trigonun çok kolay kolonize olabildiği ve elektrofulgürasyonun bunlarda hakikaten çok büyük önemi olduğu en son yazıda da ortaya konulmuş durumda.
Okay, thank you for the question. It was 15 minutes. I want to cover the most important thing, but electrofulguration is a good option. There are many articles, there are an emerging evidence that we can use for the people. The important thing is where to put each thing. In my opinion, it's just my opinion, the electrofulguration is an invasive procedure. So I started with not invasive. When a patient came to my clinic, I started with behavioral modification. Usually we recommend a combination of cranberry and dimanose, and we started with immunoprophylaxis. In patients that they had a very frequent infection, I also used instillation with hyaluronic acid and sulfate chondroitin during a month. And when no vaccination and no instillation works, I go to electrofulguration. But I think that is going in the third line. Thank you.
Ali Hocam buyurun.
Ben yeri gelmişken bu elektrofulgürasyon konusundaki fikrimi söyleyeyim. Hakikaten bu karar vermesi çok böyle kolay olan bir şey değil. Levent'in elinde elektrofulgürasyona karar vermek kolay olabilir ama yani özellikle genç meslektaşlarım için bu trigonda bazı olayları gördükleri zaman elektrofulgürasyon yaptıklarında hakikaten sonrasında kabus sonuçlarla karşılaşabilirler. Onun için çok dikkatli olmalarını tavsiye ederim. Birinci söyleyeceğim bu. İkincisi de Doktor Medina'nın intrakaviter gentamisin konusundaki fikrini almak istiyorum. Tekrarlayan üriner enfeksiyonlar konusunda.
Can you repeat the question, please?
Sure.
Sorry.
Yeah.
Just the question, yes.
My question is about the intracavitary gentamicin for the recurrent urinary infections.
Well, I try to avoid the antibiotics, and I usually had a good effect. My recommendation about intracavitary antibiotics, I use, but mainly in patients with a catheter and neurological patient, not in every territory. And in patients with a catheter, sometimes I had a good result, but mainly in neurological patient.
And I would like also take your opinion about the cystoscopy in your algorithm of the diagnosis.
Well, my opinion about the diagnosis is in some way similar that the recommendation in the guideline to patients with recurrent urinary tract infection, a normal patient, young patient, we only need an ultrasound. We don't need more study and urine culture. If the patient had other risk factor, I go for other studies. For example, if we had a neurological patient, I go for urodynamics. If the patient had lithiasis, I study with other treatment. But I usually only do an ultrasound, and sometimes it's not included in the guideline, but it's easier to me. But I usually do a flowmetry with electromyogram because there are a lot of patients with no coordinated voiding, and with feedback they improve of the infection, especially in young patients.
Doktor, artık almayalım, zamanımızı aşıyoruz. Dr. Jose Medina'ya teşekkür ediyoruz. Thank you for your excellent presentation.
Thank you very much.